Good afternoon to all the delegates and participants. I am extremely thankful to our IMA College of GP's Dean, Dr. Rayapu, for giving me this opportunity to share a very important topic in emergencies, acute medicine need of the hour. Dr. Rayapu is a highly academically oriented dean. IMA CGP is fortunate to have him. I am sure in the years to come, we will have many more academic events. You may all wonder, what is this topic, acute medicine? We have heard about internal medicine. We have heard about intensive care medicine. We have heard about emergency medicine. And we have heard about critical care medicine. This is an acute medicine. It's a new specialty which has come up mostly in the developed nations. It has its origin in UK. Now this will be the framework. I'll tell you what is acute medicine, how the history has come, what are the division, type of cases, and few examples, and what about the feature of acute medicine. Acute medicine is that part of internal medicine, general medicine, with the immediate and early specialty. It's an immediate care. In emergency, this and that care is there. Here it is more, much more acute or much more immediate. And there are acute medical units in specialized hospitals, and acute medicine hospitals are also now available in many parts. In acute medical unit, we will have these components. There will be the care area, what is the functions, and the people coming in and going out, the flow, the communications and support services, nursing care, and our allied health professionals care, non-consultants, consultants, patient review, and specialty care. These are the components of acute medical unit. They have been well, delineated and put into use in acute medical care. This medical emergency started in the year 1850, the Crimean War, wherein the Florence Nightingale, our English nurse, she initiated it, and 23 neurosurgeon in John Hopkins Hospital, strengthened it, followed by 52, 53, 60, and in 1970, Society of Critical Care Medicine was formed. And in acute medicine, the history, it's a little shorter. It started in the year 1998, only around 25 years. And the United Kingdom, the Royal College of Physicians of Edinburgh and physicians and surgeons at Glasgow, they have formed it by a joint report. And 2003, it was recognized as a subspecialty of internal medicine. The Society of Acute Medicine was founded in 2020. The Dutch Acute Medical Societies was formed in the year 2022. It's an upcoming one. What's the difference between general medicine and acute medicine? Acute medicine is a part of general medicine where there are, emergency admissions which need an immediate care. And in emergency medicine and general medicine are not same. Emergency medicines are used for cases of instant medical need of the patient. What is the example of an acute medical condition? It can be right from a acute, say, exacerbation of asthma to even a fracture of a bone due to osteoporosis. The person dealing with acute medicine is titled as an acute physician. It should be stressed that acute medicine is not the same as emergency medicine, which includes medical, surgical, all other aspects of emergencies. There are acute medicine, only acute internal medicine, whereas these two specialties always work together. The role of acute physicians here is clinically, they give an immediate care to the emergency patients, and within 24 to 72 hours, the patient is, coming out of his emergency, and sometimes in most of the cases, you may even have, a next day, they may go for a specialty triage also. The aim is, to create consultants and quality services. And there is following a completion of the founding program, they will have to undergo this acute care, and then they become acute physicians. They become acute physicians. And the training in acute medicine, there is a core clinical training in acute medicine, and trainees are expected to develop a chosen. They should develop some specialty skills, like procedural skills like echocardiography ultrasonography, or they can get an additional qualification or diploma, master's level in medical education or clinical leadership, and a specialty of interest, palliative care, intensive care. More so, they will have to have an interest in research and acute medicine, past, present, and future. By, Dowdell is, very much interesting. It is a significant point in the development of acute medicine was marked on 3rd 2003, as I said, when there was it was made, recognized as a part of general internal medicine. And the training, everything was completed in 1917 itself, the system. It was assumed that acute medical care in all situations should still be delivered by every physician. And this can lead to an ambulatory care when the patient starts improving. A consultant physician in acute medicine provides expertise in the best initial care. That is immediate care, as I said. And Royal College has certified that. And perhaps most significantly, there is a recommendation that clear pathways are developed to facilitate higher specialty training in acute medicine for doctors with a background of emergency medicine or critical care. And intensive care medicine is the one which we are all very much used to it. And doctors working in intensive care medicine manage the sickest patients in the hospital, and they have some organ dysfunction. And advanced critical care practitioners and intensive care physicians and critical care all are equal. And intensive care physicians and critical physicians or intensivists are equivalent. Types of intensive care unit is a regular intensive care unit or a critical care unit. There are any types of subdivisions here. Coronary, intensive care, medical intensive, surgical, pediatric, neuro, overnight intensive and trauma and neonatal, ICU in the emergency department. These are various subdivisions available for intensive care unit. And during the training in intensive care medicine, you have an opportunity to develop specialty skills, which can be an academic research or cardiac intensive care, echo, and extracorporeal membrane oxygenation or education, home ventilation, neuro-intensive care, pediatric and pre-hospital emergency care, quality improvements in healthcare and transfusion medicine, and live vaccines. These are various specialty. Though they are handling the patients, acute patients, they should develop these skills also. In a pre-hospital, there is an emergency call, which is triaged by paramedics, goes to designated primary emergency. Depends on the type of case. And they go there, usually they're small hospitals or clinic, and they get first line therapy and may go home or may be referred to higher level. Secondary emergency care hospital, moderate sick to be admitted to the floor. Designated tertiary care emergency care, they usually go for an admission and go for further treatments, especially in community hospitals. What is critical medicine? Critical medicine is when the vital signs are unstable and indicators are unfavorable. Is critical care an emergency medicine? Critical care is also a part of an emergency care. And there are any subdivisions available here: emergency medicine, clinical care, emergency physician, intensivist, and emergency department intensivist, and resuscitationist. There are a lot of subdivisions have come here. And general medicine now, has got many subspecialties in acute care. Emergency medicine, the wide spectrum, including medicine, surgery, ortho, OBGYN, including even pediatrics. But acute medicine and urgent care are equal, and intensive care and critical care are equal. All are subspecialties of general internal medicine. These are the milestones of acute medicine to summarize. In 2000, UK acute medical units in the hospitals and acute hospitals came up. And in 2000, UK Society Acute Medicine formed. 2003, Royal College of Physicians and Surgeons, they recognized it as a dedicated specialty. 2005, Acute Internal Medicine curriculum was established. 2007, RCP Acute Medicine Task Force report was there. 2009, course curriculum and training approved. 2012, Touch Acute Medicine was formed. And here, this is the floor diagram of a large acute hospital. There are diagnostic supports, ambulance services comes, and therapy teams are there, and critical care is there, acute surgical care. Depending on when there is an organ damage, you go for a critical care. Major trauma, mental health team, pediatrics and emergency department, acute medical units are there. They take care of an acute stroke or coronary artery disease. When they improve, they go for an ambulant care. The types of cases that comes acute medicine is the key, or the engine. There can be a cardiology case, a respiratory case, gastroenterology, or ITU, or acute oncology, palliative care, frail elderly. Anybody can come with an acute problem to the acute medicine department. The common cases that are seen in the acute medical units are, one is myocardial infarction, very common. Heart failure is still more common, and stroke is also equally common. Intracranial bleed, chronic pulmonary disease, pneumonia, sepsis, UTI, or some bone and soft tissue infection. This is the order. The first, most important here is the heart failure and chronic pulmonary diseases, usually present to the acute medical unit. These are the type of patients. Patients with pulmonary embolism and gastroenteritis, renal failure, organophosphate poisoning, acute intracranial bleed, acute exacerbation asthma, myocardial infarction, hypertensive emergencies, other poisonings, decompensated heart failure, diabetic ketoacidosis, septic shock is more common. These are the percentage and the type of the cases that present to the acute medical units. Common acute conditions encountered are an ischemic heart disease, called the coronary artery disease with the infarction or a heart failure, cerebrovascular disease or unconsciousness, GI bleed, acute infections and sepsis, cardiac dysrhythmias, venous thromboembolism, exacerbations of chronic respiratory disease, diabetic complication, complications of drug and alcohol misuse. These are the common conditions present to the acute medical units. And acute care common stem. See, acute care has a common stem. Internal medicine physician is the main stem, where acute physician, emergency physician, intensive critical care physician, physicians all, very much, in the common stem. When therapy precedes the diagnosis, that is acute care. Time is life. In acute medicine, time is muscle, time is brain. Golden hour, platinum hour. Another platinum hour is also there. Treatment delayed is treatment denied. All of us, we know. I will see a few examples. First, we will start with acute coronary syndrome, chest pain in the middle of the chest and going, radiating to the neck and upper arm. It can be a STEMI or non-STEMI. Sometimes may enter into a sudden death also. How to differentiate? ECG is the key, and it shows here an ST elevation infarction. Here is a non-ST elevation coronary artery disease, and enzymes TROP-I, TROP-T, and CKMB, and echo will always show the regional wall motion abnormality and its complication like MR, VST clot. Of course, the final court of appeal is in coronary angiogram or a nuclear scan. Caution is you should not forget about silent myocardial infarction, right ventricular myocardial infarction, normal ECG, and differential diagnosis also. Usually, you do a physical examination and ECG, all done within about 10 minutes, make a diagnosis, and get an access, and the primary medication of antiplatelet, clopidogrel, and aspirin, and enoxaparin, morphine for pain relief. You'll add a triage, complicated or uncomplicated myocardial infarction. Prepare for thrombolysis, give a hydrocortisone and chloramphenicol, ondansetron, pantoprazole. In olden days, we used to do streptokinase and urokinase. Now, tenecteplase is the drug of choice. You give 0.5 milligram per kg as a bolus. And as we give do the thrombolysis, keep all the emergency drugs and the defibrillator ready. And you must anticipate complications like hypotension, or can be a cardiac failure, or a VPC, or a VT, or left ventricular failure. You should be ready to manage this. And the thrombolysis can be done in 3 places. One in the emergency room or ICU. Emergency room is preferred because the door to time is reduced. Home versus ambulant thrombolysis is also an integral part in emergencies. Ambulant thrombolysis is always better. Supportive drugs, there are 2 important supportive drugs. One is nitroglycerin, and when the blood pressure is above 100, or dopamine if there is some failure, when the blood pressure is less than 100, a high dose steroid, atorvastatin and AC inhibitor and a beta blocker, especially cardioselective. Very rarely you may have to give a glycoprotein 2B, 3A inhibitor, and sedatives have to be continued. Now you should check whether this thrombolysis is successful or not. After 90 minutes, if the ST segment is elevation has come down and pain is totally relieved and patient is sleeping and there is a peaking of CKMB, always shows you that there is successful thrombolysis. Of course, who needs primary coronary intervention? See, we said that CAG is the final court of appeal. PCA is the first treatment of choice in acute myocardial infarction if it is readily available. Don't delay. Good opening of location and opening of the infarct artery, which we call it as a primary PCI. When it is not available, when the patient is very sick, initially do a thrombolysis, then go for a rescue PCI. And when there is a pulmonary edema, we will have to be very careful and you complete the thrombolysis, stabilize the patient, then take him for, coronary angiography. This is a system of management. The patient comes to you in less than 3 hours after the chest pain, PCI available, primary PCI is a drug. Not available, thrombolysis. Successful, you do a delayed PCI. It is failed, you will have to go for immediately a rescue PCI. If he comes to you after 3 to 12 hours, only a PCI is the drug of choice. You can always start an heparin, and but PCI has to be done. More than 12 hours, only option is a PCI or a CABG. Usually they will end up in a angiography and a CABG. The second common syndrome that we see in the acute medicine department is a stroke. If elderly gentleman comes with altered sensation, weakness of one half of the body, usually we call it as a stroke, which can be 80% thrombotic or embolic, and it can be hemorrhagic for about 20%, and cortical venous thrombosis can be about 1%. Always think it would be an ischemic infarction. You will have to, of course, locate the site of lesion clinically. When there is a upper limb weakness and confusion, anterior cerebral artery. When it is a facial weakness with hemiplegia, it's a middle cerebral artery. Cortical blindness or hemianopia or vertigo, PCI, posterior circulation stroke. Gerstmann syndrome is caused by non-dominant parietal lobe infarction with agraphia and right to left disorientation. Lacunar infarcts usually have very minor symptoms. When there is a brainstem involvement, there can be a cranial nerve on one side and then hemiplegia on the opposite side. We call it as a crossed hemiplegia. Acute focal deficit, no CT scan or bleed is always very important to start the next level. The clinical clues are hypertension, peripheral pulse, carotid, and cranial bruit, and in the cardiac side, any valvular or shunt lesion, respiratory lung disease, and abdomen, renal artery bruit. You do a blood chemistry, ECG always do, echo do, Doppler do, and MRI with MRA, MRV, and you will be able to say, look out for a thrombus here. You will be able to look out for a thrombus in the myocardium. You will be able to see an infarct here, large infarct here. Always search for the source. And thrombolytic therapy, intravenous, and there should not be any bleeding in CT, then only you go ahead. Patient is conscious, not BP very high. RTPA is the one, or tenecteplase can also be given, 10% as bolus, remaining over about 1 hour. And you can combine glycoprotein 2B and 3B inhibitors and need a follow-up CT. And heparin, we don't start simultaneously, we start it immediately after, this thrombolysis after 4 hours, because we want to, prevent an intracranial bleed. Supportive therapy, heparin, you will have to give, anti-edema measures, some neuroprotective agents and antiplatelets and physiotherapy. Interventional procedures sometimes may be needed. What interventional procedures is an intra-arterial fibrinolysis. You go into the cerebral angiography, go into the vessel, do an intra-arterial, thrombolysis. And you may have to, extract the, thrombus there and do a recanalization. And All of them can be done, with the help of a, cath lab. But only ischemic penumbra will improve. Once there is a damage and infarct, that infarct cannot be, brought back to life. All of us know that. This is a system. Presentation of an acute stroke. There is an ischemic stroke and you do a CT and go in for a thrombolysis. When there is a major occlusion, you will have to go for intra-arterial thrombosis and you may have to go for, when it is continuing, a mechanical thrombectomy. Hypertensive hemorrhage, only surgical. Non-hypertensive hemorrhage also, you do some supportive measures like anti-edema and anti-seizure, and then you'll have to go for a surgical measure only. This is a system. There is an ischemic stroke in general, 1 to 3 hours, no ICH, you go for thrombolysis, if needed, a mechanical. After 6 hours, only mechanical and apparent. If there is a source, for example, if there is a, carotid artery, plaque, or there is a, embolus, or there is a, mass lesion in the cardiac system, has to be managed. Coming to the, another important acute medical emergency, pulmonary edema. Usually it is due to increased pulmonary capillary pressure or increased permeability or decreased oncotic pressure. And that is a reason for this. But usually it is a hypertension or a coronary artery disease or a valvular disease. Patient has severe orthopnea. X-ray chest shows a bat swing appearance. You must remember, and echo is always confirmatory. All that visas are not asthma. In the emergency department, you should not think that it is a, acute exacerbation. You will have to do all monitoring and you may have to do sometimes early non-invasive ventilation. But the key, drug of therapy is diuretic. Diuretic to reduce the, lung, flooding. When the systolic, based on the systolic blood pressure, when it is above 100, nitroglycerin, diuretics, double the dose, and positive pressure ventilation. Sometimes an ultrafiltration have to be done with a dialysis machine to remove the fluid. When it is between 90 to 100 also, nitroglycerin, dobutamine. Below 9, there is no need for NG, dopamine, dobutamine, noradrenaline, keep the BP above, and intra-aortic balloon pumping may be needed with or without a PCI. And another important acute medical condition is unconsciousness. Patients being brought by relatives saying that he is unconscious can be many causes. Vegetative state, acute mid-tissue metabolic coma. Always you do a clinical examination. There is a cerebrovascular accident, there will be a CVA. There is a CNS infection, there will be neck stiffness. Metabolic coma, all clinical features are normal. Sometimes associated features can be there. Sedative overdosage, people are spared. Psychiatric illness always have to be kept in mind. Always have to be kept in mind. Clinical diagnosis is always vital. You will have to evaluate with an ABG and a CT to rule out intracranial problems and all, blood chemistry and triage, medical and surgical. And coma, CT positive and CT negative, that is how we do. CT positive is ischemic or hemorrhagic or a SOL or trauma, you manage accordingly. CT negative, usually metabolic or post seizures or early meningitis or hypertension itself of the, with clinical correlation, you will have to manage it. Another important acute medical problem is an acute upper GI bleeding. Usually common in alcoholic, they comes to the hospital, may come with a hematemesis or melena. Sometimes they usually come with a giddiness and sweating and pallor, and we will have to check the blood pressure, and it can be a non-varicose or varicose. First is it can be due to ulcer or varicose, malarial viscer or malignancy. You will have to assess the clinical status of the patient. The vitals have to be resuscitated. First important thing that we do in acute medical unit, start a twin IV line and straight to stabilize the patient and bring the blood pressure up, and simultaneously evaluate what would be the cause for the bleeding. And there is a non-varicose bleeding, usually PPA and prokinetic and gastric cooling. You put in a right strip and see whether there is bleeding. And through that gastric cooling and then there is a varicose means you will have to go for a octreotide, somatostatin or telepressin, balu tamponade. These are medical management, whereas endoscopic management is the key. In non-varicose bleed, an injection of ephedrine or ethanol thermal methods or mechanical clips can be put in the bleeding sites. Endoscopic management of varicose is a varicose ligation or injection, intravascular injection. Of the varices is the therapy. This is the algorithm of approach to patient with acute variceal UG bleed. That is a gastric varus or esophageal varus. Immediately you will have to go for a ligation or a sclerotherapy and do a follow-up after 4 hours and free discharge, and may need sometimes a surgical one. When there is a non-varicose, usually it is a conservative management to put in a Ryle tube, try to cool it along with PPIs and prokinetic agents. We will be able to do that with supportive management. And another important thing is sepsis, which may not present with even fever. Sometimes there will be unexplained fever, sometimes without fever. Tachycardia and tachypnea with reduction of the blood pressure is very important. And here there can be many types: bacteremia, septicemia, SIRS, sepsis, severe sepsis, shock, organ failure. Always tachycardia, tachypnea, hypotension. Always think it could be sepsis. And there are general symptoms are there. Organ failure can be there. Early recognition is important. It is a treatable condition. More than 50% of patients with sepsis can be, saved. You will have to go for adequate fluid management and organ support and antibiotics. You will have to have an antibiotic system. Before culture and sensitivity, that institution should have the system, what antibiotic to be used in which conditions, depending on the blood urea and other conditions. Here a careful history and examination, imaging, bacteriology, IV fluids, ABG, and organ support usually comes to a good outcome. Common bad pathogens are staph and pseudomonas. When you use an antibiotic combining both, it is good. This is a review of acute medical unit in various hospitals. It shows that it reduces the inpatient mortality. The length of stay and emergency department access is always reduced, and readmission rates are less. Improves patients and staff satisfaction. The outcome is conventional specialist-led care. Here, current internist-led acute care that gives good outcome. Early discharge also, satisfaction to the patient. These are the hospital outcome measures. The death rate and everything is being reduced, and that even expenses are reduced. Acute medical unit, there is an experience from a tertiary care center in Singapore that shows that this gives an excellent results with the increasing number of aged population in Singapore. Acute medical conditions are very common. They are referred to acute medical units. When they are given a holistic care and supportive care, their life is very much saved easily, and patient gets early discharge also. Therefore, in developed nations also, there is a important conclusion that acute medical units saves the patient's life better and reduce disability and early discharge, leading on to less expenses. Now, learning from acute medicine is door to ECG 10 minutes in chest pain. Door to needle is 30 minutes. Door to balloon is 90 minutes. PCI. In stroke, less than 10 minutes at the emergency room. Neurologist 15 minutes. CT 25 minutes. And interpretation 45 minutes. And thrombolysis 60 minutes. In antibiotics, you will have to give it less than 2 hours. Antibiotics and fluid management. Golden hour is the treatment and early diagnosis. The first platinum hours are very important, 30 minutes. And first 10 minutes is always crucial. Adult acute care medicine is, stressing that time is life. Why acute medicine? You may all now be very clear. For the early recognition of acute problem, triaging, immediate management, clinical intervention stabilizes, and can be transferred to interventionist or intensivist. Acute physician is the key. Future will be in all acute hospitals will be dominated by acute physicians and acute medical units, so that they can give better patient outcome. Now the learning points are: treatment delayed is treatment denied. Timely diagnosis and intervention saves life. Never ignore symptoms, unusual symptoms, unexplained symptoms coming for the first time in their life. Evidence-based and experience-based must have a good mix. And time needs team. Time is with acute physician. Acute medicine is the need of the hour. Thank you. Thank you so much. I think I have conveyed the best on acute medicine, which will definitely help you in your future practice and patient care. Thank you. Thank you all very much.